two of the questions that came up that I think actually are a perfect little transition. One was, if digestion is slow, how does taking another pill help? So I thought that one kind of leads us right into Duopa. The other one was just around constipation and, how do you deal with constipation, and can you take Miralax every day? And, that also ties into then I think Duopa net delivery system.
Right. So yes, you can take Miralax every day. So on your Miralax bottle, it says, oh, if you're taking this more than 14 days in a row, please call your doctor. So most PD patients will need to take Miralax once a day. Some people actually twice a day. So because remember that constipation is part of the non-motor symptoms of Parkinson's disease. It's the reason why your medications aren't working in Parkinson's, because they're going through the gut. And so the patient had asked, well, if I took my medicine and it's not kicking in, what if I take another pill? And then what happens then? Many times, now you have two pills in the stomach, and then both of them end up in the small intestine at the same time. And now you have on-time-with dyskinesia, because these three pills that are floating around there all made it into the small intestine at the same time. So many times when you go to the GI doctor and they do a scope, they do an EGD, many times we see little yellow sediment stuck in that stomach. It's still hanging in there 3 hours after you've taken the pill. And so Duopa is a Levodopa gel that we use a pump to go straight into the small intestine and deliver the medicine continually. Every 57 seconds, you're getting a dose of Levodopa right into the small intestine, more like the normal brain, so that we're not getting stuck in the stomach. It doesn't matter so much whether or not you're constipated or not. And so we're delivering the medicine exactly where it needs to be, and we're flattening that curve. If you go to the next slide, Sarah. So remember how that therapeutic window gets smaller and smaller, and you see that sine graph, we're always, the smaller it gets, the more likely we are to be either above the line or below, so that you're on time with dyskinesia because two pills got there at the same time, or you're off because you're constipated and none of the gut is moving. It's just taking longer for that medicine to kick in. So one way to eliminate all of that, especially once you have advanced disease, we've gone through rytari, you're having a lot of trouble, you're taking rytari more than 5 times a day, then we would offer you Duopa as the next step in therapy, where we infuse the Levodopa straight into the small intestine and give you a continuous dose of the medicine. Right now, the FDA approves it for 16 hours a day, but I would say that half of my Duopa patients are taking it over the 24-hour period, especially patients who have a lot of trouble with sleep and sleep fragmentation. We run the pump 24 hours off-label, because you don't stop having Parkinson's disease at night because you fell asleep and then stop taking Levodopa, so that we can do that off-label. So patients don't wake up off as much. It doesn't take them so long to kick in the morning because they've already had a continuous dose of medicine. And again, it's delivering that Levodopa every 57 seconds. So the pills don't do that. Nothing does that other than Duopa right now on the market. So the only minuses of that is that right now we still have to deliver it through a PEG tube or a medication port that goes into the tummy, and we attach that tubing to the pump, and then you have to carry the pump. So you just carry it in a fanny pack, or it's not as small and compact like an insulin pump. But many patients, their worries initially before they start Duopa therapy is like, oh, the pump, it weighs too much, it weighs a pound, how am I going to carry it? What if I want to wear a dress? All of that goes away once they've been on all of the time. So far, nobody has said to me, you know what, I want to pull this tube out and I want to go back to taking Cinnamon 8 times a day. You forget all about that because you kind of forget about Parkinson's. Your alarm isn't going off on your phone 6, 7, 8 times a day. You can get a divorce from the phone. And so you have more continuous on time, less off time. The other thing that's nice is that, remember we were talking about, rock steady boxing, and that maybe your Levodopa wore off a little bit earlier because we burned through that Levodopa. The Duopa pump has an extra dose button on it, so that if you need an extra dose, just like you would take an extra pill, you can add the extra dose, and it gives you that extra medicine if you needed to do power gym or rock steady boxing or physical therapy, so that you, when you fall down into that off time, you can quickly get back into that therapeutic window.
So I'm curious, so one person asked about, you referenced that, so it's a 16-hour pump that you, at least half of your patients take it during the morning, and then also, you know, through the night, and that helps them not have off time during the night too. Because somebody asked about freezing of gait and dystonia during the night. And so do you find that that helps to make, you know, the evening and sleep time better because they're getting the very, very regular dose of?
Right, so your off time would be less, and many patients have off time at night because they're not dosing levodopa at night. So that, you know, you go to bed, you take a dose of cinnamon or rytari, but then 3-4 hours later, you wake up, you go to the bathroom, and then you go back to bed, and you can't fall asleep because you can't turn over in bed, your body's uncomfortable, it's stiff, it's rigid, you might have a tremor, and so it's hard to go back to sleep. Your body can't relax enough to fall asleep again. That's called sleep fragmentation. And again, low levels of dopamine interfere with the normal stages of sleep. So you're not going through stage 1, 2, 3, and 4. And so if we can continue giving you dopamine, it's one of the reasons we use once a day dopamine agonists like Mirapex ER or Requip XL or Nupro, is that we can cover some of your symptoms throughout the night. Then that's why I like to run Duopa at night as well, because we can smooth that out and patients sleep better. The better you sleep, the better your next day is. So remember, sleep is really important. Like, why as humans are we spending a third of our life asleep? There's something else going on. Otherwise, we wouldn't be asleep all of the time. And sleep is when learning and memory gets consolidated. So your short-term memory turns into long-term memory. What you learned during the day, whether it was like a new piano recital or skateboarding or pottery, all of that gets consolidated at night while you're sleeping. The other thing that happens while you're sleeping, which is really important in Parkinson's disease, is that all the housekeeping and cleaning up of the cells debris is happening at night. And one of the problems in Parkinson's disease is that you have alpha-synuclein, which is misfolded and can't be cleared out of the cell, and it forms a clump called the Lewy body. It causes the cell to die. So the more sleep we can get, the more we can clean up and do the housekeeping of the brain during the night, and the better, hopefully, the more we'd slow down the disease. But it's one of the things that is happening in Parkinson's disease. So the more we can get you to sleep, and we want that stage 3 and 4, that deep sleep to happen, the better your learning and memory is, the more we're cleaning up all of those misfolded proteins in the brain.
So it seems to me that it's really important then that people really do explore the different therapy options, because I feel like sometimes, at least from what I hear from people, it's really common to just keep, you know, sticking with the same one, but upping the dosage. And I think this really goes to the unique expertise that a movement disorder doctor brings to the table to understand what's really happening in that disease process. I think that, you know, as you talk about that, what you're trying to do really is get people back to, I think you said it, where they're not having to think about Parkinson's all the time, and they can actually live.
Right. So our goal is to divorce you from your phone and from having to be taking pills 6, 7, 8 times a day and having to think about your Parkinson's disease every 3 hours because you wore off. Our goal is to get you back to doing everything you want to do, to playing golf, to going to brunch, to playing bridge, all of those sorts of things, and not have to be constantly reminded that you have Parkinson's disease, whether it's early in the morning because you can't get out of bed or you can't turn in bed, or because you wore off after 3 hours. And so in the past, we never had any medicines that lasted longer than 3 hours. I mean, 20 years ago, we did have patients on what we called liquid Cinemet, where we would make our own version. We would crush up your Cinemet pills, we put some vitamin C in it, and then literally the patient would sip the liquid Cinemet all day long, sip, 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 to keep you on, because, you know, it's very difficult especially if you're constipated, which most PD patients are, for your medicines to work well, because you're taking them literally 1.5 hours every 2 hours in advanced disease, so that you're spending most of your day off and most of your day catching up. So now, instead of doing our own liquid Cinemet concoction, now we have Duopa for those advanced PD patients. And really, we found that the best combination for PD patients is DBS and Duopa. So it's two therapies that are 24/7, always on. You're not peaking and troughing throughout the day, and they seem to do very, very well.
So what do you think it is about the two? I mean, I think that's also important for people to know. You know, this doesn't, as you're looking at your therapies, it's not always an either or. You get to actually be on the very best thing for you. So what do you think it is about the two of those together that really helps to just kind of be the, you know?
So there's two ways that your brain communicates. And so one is electrical. That's how DBS works. It's an electrical system. So we're doing a little bit of voltage into the brain. And then the other one is chemical, which is what Levodopa or your oral medications are doing. So if we can talk to the brain both electrically and chemically, then we're talking to the brain the way it usually does to itself. So those two ways are working well. And then the things that it's continuous therapy. Your DBS doesn't turn on and off every 3 hours. It's on. You turn it on unless you turn it back off. And so it's always working for you. So it's always slowing down the dyskinesia. It's always titrating, dialing out the tremor for you. So, I mean, that's the oral medications don't work like the way we want them to, because they're always getting stuck, and we're not getting into the small intestine, and then we're at the mercy of the metabolism of the pill. If the pill only lasts 90 minutes, then we have to take a next dose in 90 minutes. So that, we're the normal brain just doesn't turn off every 90 minutes the way Levodopa does.
So it's that steadiness that really, and I'm pulling up, somebody asked what the pump looks like, so I'm going to pull up a picture to show them that. And somebody else asks, what is an under the tongue dose?
So Synovian is going to come out with a new therapy, which is a rescue medicine, which will be like a little tab, like a Listerine tab of apomorphine, a dopamine agonist. That will be a rescue medicine. So that if you're having trouble swallowing, then you can, with Ambrosia, many patients have trouble with a cough, or they cough out the powder and so they can't get it into the lungs. This would be another way to treat your off period by putting that little Listerine thing under your tongue and letting it absorb in the mucosa of the mouth. So it'd be another way to deliver medicine without having to swallow a pill.
Perfect. And somebody sent me a private question asking about any experience you have with malfunction of the pump, or do you see that as an issue very often?
So we had to replace some pumps, but whether the battery wasn't working or there was some problem with the pump, then you just send it back to AbbVie and they FedEx a new one to you in 24 hours.
Okay. And with that too, right, when you're starting on Duopa, there's like a nurse involved, or if people are considering it, I want to say that there's like, they can call and talk to a person, and care partners too, right, can talk to a person who uses the pump to really hear from them, their experience.
Yep. So just like DBS, we think it's very important for patients to talk to other patients who've been on therapy so that they know the good, the bad, and the ugly. And so would they do this over again? What do they like about the therapy? What don't they like about the therapy? So AbbVie has a very good program where you can speak to a nurse and you can speak to a patient ambassador. You can speak to a male or a female. Many women want to know, like, how do you wear a dress, that kind of thing, so that you can talk to them and ask them your questions and your concerns. And so the nurse will come out and visit you initially, show you the pump, the tubing, all of that sort of stuff. And then they will come visit you again after you've had the peg to place, and then help you with any troubleshooting. And the same thing, you can talk to these patient ambassadors at any time you want to.
Okay. And somebody wondered what happens with the pump when you're swimming.
So you can go swimming. So all you do is you just unhook the pump from the tube, you cap off the tube, and then you can go swimming, do whatever you want off the pump. If you're off the pump more than 2 hours, we may dose you with a dose of Cinemed or Levodopa or rytari. If you're off the pump less than 2 hours, usually you do not need any medication. So certainly you can be off the pump whenever you want for any activity that you want, whether you wanted to do swimming, scuba diving, whatever that is. And then you just hook the pump back on when you're ready to go. The same thing with a shower.
Okay. And somebody did ask me about support groups, if there's support groups for people who have, who utilize the pump, and I know there are some support groups. So if you want to connect with us, we can help link you in with some support groups, just like there's support groups for DBS. You know, there are some groups for the pump. Let's see, there is a question tied to traveling. Thanks, Rebecca. Rebecca put the info at pmdalliance.org in the chat. There's a question tied to traveling, and I want to say, I'm going to not be 100% sure if I get this right. So this person likes what the pump does, but it is afraid to travel because you have to wait until you come home. And I'm not sure if that means to get medication or, so I'm not sure what that is, but maybe even if just talking a little about traveling, and then if you want to tell me just a tiny bit more, I can see if I can ask that specific question.
Sure. So, you know, the pump uses a cassette, which is the gel form of the medication, which needs to be refrigerated before you use it. So AbbVie will send you a month's supply of so they'll send you 30 cassettes, which you will keep in the refrigerator. Then every day you take the cassette out and it thaws out in 20 minutes. Now in Arizona, you just put it outside, 5 minutes later, it's ready to go. And then you use that for the rest of the day. If you travel, so you can travel with the pump. So let's say you're a snowbird and you spend the winter in Arizona and the summers in Wisconsin. You just tell AbbVie or Accredo, the pharmacy, hey, I've now moved up to Milwaukee, and then they'll mail you your supply of medicine to your new address. They can mail your medicines to any address in the United States, including Hawaii and Alaska. They cannot mail it outside of the United States. So, like, I mean, we had some patients who were going to go on a cruise this summer, which all of that is canceled now. But what you would do is you would just take extra medicine with you onto your cruise or to Europe and be able to travel out overseas. That's what the pump looks like. So this part here, that's the cassette that has the medication, and then that's the 1980s version of the pump. Hopefully one day they will make it look more like the insulin pump. So, but your medicine can be mailed anywhere in the United States. If you travel overseas, then you would have to carry your medicine with you. They do provide you with a cooler so that you can take the medicine with you, you know, through TSA. So as long as the medicine is cool, it's refrigerated, then TSA says, yes, you're a PD patient with medication. If it's liquid form, then TSA says, oh, this must be a terrorist. They'll confiscate your medication. So you make sure you just keep it in the cooler, that it's refrigerated, it keeps cool, and there should be no problems getting to TSA. The same thing.
Have you ever heard of anybody? Sorry, go ahead. Go ahead. Sorry.
So, and if you travel outside the U.S., usually it would be under 30 days, and you should be fine.
Okay. And have you ever heard of anybody who is traveling and then has difficulty with the pump? So that was the question, is if I travel and then something happens to the pump, then am I just going to be stuck? You know, how quickly have you seen responsiveness? That's a great question.
So the AbbVie 800 number is 24/7. So you can call it any day or night from anywhere in the United States or even outside the country. And there's always a nurse on board that can troubleshoot the pump with you. We can also program the pump just like we program DBS, where you can, you know, go up or down on your limits, whether it's the morning dose or your continuous dose. So let's say you wanted to bump it up or lower it, you can call the 800 number, talk to the Duopa nurse, and they'll talk you how to change those settings if your neurologist has allowed it on your pump. So there's always an 800 number, and there's always a nurse at that number.
And I'm going to ask for people to put in the chat really quick yes or no to this. Do you see a movement disorder doctor? Actually, you could go yes, no, or I don't know. But I'm curious, do you see a movement disorder doctor? Just curious about that. All right, I'm seeing some yeses. I'm just going to watch for any outliers. Dr. Ospina, while that's happening, there was a couple things that came up, and we will circle back after this and send information to you so you know exactly where to find this. As Dr. Ospina mentioned, we have on our website the list of all the medication assistance programs, and there are many, and each medication has one as well, but there's other programs. So we have that on our website, and we'll send you a link to that as a follow-up to this so that you have that and you can take a look at it. And somebody else asked about, wow, I didn't know about some of these medications, haven't heard of them before. And we have talked about quite a few different medications, and we're so fortunate to have so many medication and treatment options. So we will include in there also a link so that you can look at all of the medications. We only list ones that are FDA approved. So if they're used, as Dr. Ospina referenced, some things are used off label, that's maybe not on there, but we only put things that are FDA approved, but there's a lot of information out there. One question that came up, I take Carbidopa, Levodopa 4 times a day, Nupro and Inbrija. Is this an indication that I might be a candidate for other therapies?
So if you're only on Nupro and Inbrija, then you're very early on. You're only just taking the Levodopa form of Inbrija. So always remember, we make sure that the benefits of the medicine outweigh the side effects of the medicine. And we would start off with oral versions of Levodopa, like Cinnamon or rytari first before we went to the pump. But once you're on Levodopa more than 5 times a day, then we would consider offering you the pump. Most patients don't want the pump. They're like, oh, I don't want this peg tube. I don't want to carry this pump sort of thing. And so they're taking Levodopa 8, 9 times a day. I think as time goes on, just like what happened with DBS, and there's more people going to support groups on Duopa like they were with DBS, it'll become more common and less sort of scary for patients. Because right now, if I offer patients, now we're ready for DBS or Duopa, 9 times out of 10, they still choose DBS first before going to Duopa, even though DBS is the most invasive part of the therapy. We're doing brain surgery, we're drilling 2 holes in your head, we're putting hardware into your brain, whereas Duopa is completely reversible. We're just putting a tube into your stomach and that's it. If you don't like it, 6 weeks later, we pull the tube, everything goes back to normal, the stoma closes. So it's much less invasive and fully reversible. But because not that many people know about it and more people know patients who've had DBS, they're still choosing DBS first. I think that will change. In the future, we would be doing Duopa first and then DBS.
Yes, great. And somebody else had a question if rytari is something that can be used for people with PSP.
So with PSP, remember, they don't respond to Levodopa. So we would do a Levodopa challenge, and so that we would do that with regular cinnamon and titrate you up to 1,000 milligrams. If you had some response to Levodopa, then yes, we could use rytari because we would use it less times during the day. But we would want to see if you're responsive to Levodopa first. And the same thing with rytari, not only do we use it in advanced patients, but we can use it de novo. So if you've never had any medications, it can be your first line therapy. The only problem with that is trying to get it through your insurance company. But I mean, that would be our first goal. Choice would always be using the longest form of the medicine, the one that works like the normal brain, rather than giving you medicine every 3 hours.
And just so you all know, this is, there's so much information about both of these therapies as well as the many other therapies that we encourage you. I have listened to the rytari presentation many times, and we didn't do the formal Duopa presentation here. We will be doing that. I think it's next month. You'll get a notice about that. But what I encourage you to do is feel free to always join in. Every time I listen to one of these talks, I learn something because you guys ask different questions. The doctors have, Dr. Ospina will have new and different experiences with people. And so it just really adds to the richness of understanding it. I should have started off this whole conversation by telling you why we're so passionate about doing these kind of programs. And that is because, you can't just decide to run down to Walgreens and get, rytari, and you can't just run over and get Duopa, like none of these, or any of these medications. You have to talk to your doctor about them. But we fully believe that you are at a disadvantage if you can't have a conversation with your doctor. And your time with your doctor is so precious that if we can help you understand what's happening in the disease, and if we can help you understand what the treatment option is and what different treatment options are, whether they're right for you or not, it lets you have a more informed conversation with your doctor. And I think it's also, we're really fortunate that we have these. I have shared, for those of you that have seen me in a live workshop before, I have shared, I every month, and I inject myself with something for my migraines. I have really no idea really what it is. And I really don't actually know what it's doing, but I do it because it helps with pain and it's effective. But I'll tell you what, if there was something like this, that some doctor would actually be able to give me a full understanding of what's happening in my body and then what this therapy is doing, that's such a gift. And it's a gift that we have in the Parkinson's and movement disorder community. So we're pretty passionate about sharing that, because you're at a loss if you don't have the information. And I love the way that Dr. Ospina explains these things. Let's see. I think maybe there's another question. I just had to go off and say that real quick.
And both of the drugs are covered by insurance. So many times your insurance may ask us to do a prior auth, but because most of you have already been on Sinemet or Levodopa, it's just a matter of doing the paperwork and getting it covered. So we haven't had any denials, except for one. We did have one insurance that they approved the pump, but not the gel, not the medicine. So.
I was reading Ken Schiff's thing because we were asking about slides and FDA and all of the different, criteria that we have to work around. So Ken, you made me laugh. We will include in our follow-up email too. We'll let you know when these presentations are going to happen again. I saw most of you do see a movement disorder specialist. Maybe Dr. Ospina, we've got just 5 minutes left. We added, we made this one a little bit longer because we knew we were covering 2 therapies and we didn't want to rush through each therapy. But I'm wondering if you could just say a few minutes about telemedicine, because one person referenced, they have to drive 100 miles. Some people have 80 miles. And now we don't have that problem, because now you can see a doctor just like this, by the way.
Right.
Except for not with all of your other 100 friends on here, just you and the doctor.
So before, the barrier for telemedicine was always the insurance companies, always Medicare. You had to have very stringent requirements that the patient had to be in an underserved area and that they have to be in a Medicare compliant telemedicine gizmo, and they have to be going to another doctor's office. So now with COVID-19, all of those regulations have been relaxed. So now we can see patients on telemedicine on any platform, even on an iPhone. And we can see you in your home. You don't have to go to a Medicare point of care facility to be seen. So everybody can be seen from their home. They don't have to travel anymore. And so I think that, everybody's expanding telemedicine. And so certainly patients that live in rural areas far away in Sholo and the Navajo reservation, who've never had access to a movement disorder specialist, now we offer telemedicine. You don't have to travel 100 miles to go see the doctor. You can see them from the comfort of your living room. So I would take advantage of that. I think that Medicare will continue to have these relaxed rules at least for the rest of the year. And I think if we get telemedicine really entrenched, it'll be very difficult for Medicare to roll back the regulations and say, oh no, we have to go back to what it was before COVID-19, and you have to travel 100 miles to see your doctor. So I think, once we get these programs up and running, and then Medicare can see how well they work, that when it's time for the pandemic to be over, we can tell Medicare, look, we should keep the rules the way they are so that we can see, we can provide more health care to more people, especially access to specialists like a movement disorders neurologist. Oh, Sarah, you're muted.
Sorry, thank you. If you need to connect, let us know. But yes, that you can see a movement disorder neurologist right now from your home, and that is an absolute blessing. Okay, I know I'm gonna cram in 2 other quick questions. Okay, we have 2 minutes, I can do it. One is, if exercise decreases on time, if exercising decreases on time, I think maybe that means off time. When is the best time to exercise?
So exercise is really important because exercise, remember how we said these medicines are purely symptomatic? They don't stop or reverse the course of the disease. They just treat the symptoms. And they only treat the motor symptoms of PD, and they make the non-motor symptoms of PD worse. But guess what? Exercise may slow down your disease progression, and not only does it help your motor symptoms, but it helps the non-motor symptoms. It helps with constipation, it helps with mood and cognition. So it looks like, remember what we said earlier, that there's cells deep in the brain that produce dopamine, and for whatever reason, those cells are dying off. Exercise, it squeezes out this thing called BDNF, or brain-derived nerve growth factor. Think of it as Gatorade for the brain. So it makes those cells that are still living, still producing dopamine, and makes them make new connections. The more connected they are, the more robust and healthy they are, the slower they die off, the slower the progression of your disease. So many patients find that they feel better the more they're exercising, and what we found during this quarantine over the last 6 weeks, that patients haven't been going to their physical therapy, haven't been going to their exercise classes. They're getting stiffer, they're getting more rigid. You can really see the difference between doing exercise on a regular basis and not doing it. And so it's very important to do the exercise. One, that maybe slow down the disease progression. It helps your motor symptoms. So not only does it keep the brain young and healthy, but it makes your muscles and your bones strong. So in Parkinson's, you have bradykinesia, or slowness of movement. If you're not moving your arm, you're not swinging your arm, those muscles start to atrophy and waste away. So if you're not getting in and out of a chair, those quadriceps that get you in and out of a chair starts to waste away. And then if the muscles aren't pushing and pulling on the bone, then the bone leaches out the calcium. It doesn't suck the calcium from your diet or your supplement and deposit it in the bone because it's very expensive. It needs that pushing and pulling from the muscle to get strong and healthy. So that's where that resistance training comes in. So just like you want to have a well-balanced diet, you want to have a well-balanced exercise program. So aerobic exercise that keeps the brain young and healthy, keeps those cells living longer, and resistance training to make your muscles strong and the bones strong. And so the patient asks about, well, what if I run out of medicine? So many times we'll have you dose right before you exercise so that you have enough gas in the tank to get through your exercise. You can add a little bit more gas in the tank so you don't run through all that levodopa, but it's very, very important to do exercise on a regular basis to slow down the disease and to help your motor, non-motor symptoms. Remember, exercise keeps that gut moving, helps you with the constipation, which helps you absorb your medicines more efficiently. So if you need to, you can dose a little bit early with your dose of levodopa, or add a little bit extra so that you don't run out of medicine at the end of your exercise program. Sarah, you're muted again.
Oh, geez, here I did it again. Okay, thank you so much. Wow, what a lot of information, and I'm so grateful that we had everybody on. Really great questions. Next time when we tackle the Duopa thing, there's some questions about inpatient, outpatient, how all of that works, and we'll make sure to cover that. And definitely you can talk with your movement disorder specialist about that. We will follow back up with some additional information for you, and just thank you so much for being here. Just wonderful to see you all. Before everybody goes, if you have a camera and you can turn on your camera, it's time for us to do the PMD Alliance wave. So I don't know what that is, but we're gonna trademark it. So thank you. And thank you, Dr. Ospina.
Sure.
You're the best.
For all your questions. Mm-hmm.
Yeah.
Thank you all. Wonderful to be with you. See you again soon.
Okay, bye-bye.